Okay, everybody, this is the beginning of the bipolar disorders, the nursing process. And we're going to be starting with the first slide here, which is your assessment. And the big thing to know about your assessment is just that to make sure that we do a thorough assessment. Basically, we covered this assessment, both subjective and objective, on the first day of class when we were talking about bipolar disorder, mania, hypomania, and the signs and symptoms that go along with that. Subjectively, what types of thoughts are the person having? Usually they're having racing thoughts, flight of ideas, that sort of thing. Objectively, these individuals who with a bipolar disorder, if they're in hypomania and mania, are in a constant motor state. They have difficulty stopping to sit down to eat, stopping to sleep. Many times, as I said before, they might go days without sleep, but maybe taking little cat naps, but basically days without sleep. Also that pressured speech that we talked about and impaired ability to work. So that gets us into the nursing diagnosis, and when we talk about nursing diagnoses, we're going to go right into outcome and into interventions. So risk for injury is the first one, and always the top priority. So risk for injury, what would that be related to? It could be related to a lot of different things. It could be related to their impaired thoughts, if they're having some delusional thoughts about wanting to hurt somebody or hurt themselves. It could be also related to poor judgment, if they aren't able to judge that, okay, I shouldn't be jumping off this bridge, or if they have poor judgment with, if they're delusional and somehow they start thinking that they can fly. Many times they might have poor impulse control. Say in social interactions, they might not know that they shouldn't be hitting somebody, or they know they shouldn't, but they just can't stop that impulse. Oftentimes these people are also very hyperactive, and so they might lose control easily, bump into objects, might irritate others very easily, start fist fights, start different types of fights, might hurt other people. So that's what those would all might be related to. The outcome is basically that we want to prevent injury from happening. Okay. Interventions here, we definitely want to provide a safe environment on the inpatient unit, and the environmental milieu is set up with all those safety things that we've gone over before in place. Some other things that we can do is decrease the environmental stimuli. If a person is very manic, we want to keep them as much as possible, keep the unit quiet, keep them, quiet, not doing a lot of activities that are going to escalate their behavior. So it might be quiet one-to-ones. It probably is not a good idea for them to go into a group where they're doing a lot of processing and activities and that sort of thing. They're going to be easily distracted, and they're going to distract other members in the group, so that's just going to be overstimuli. If we try to choose games or try to choose activities that will be non-competitive and not get the person all riled up and that sort of thing. Many times if we have a choice between an open unit and a locked unit, we would want them to be on a locked unit because of their impulsive behavior. They may be at risk for elopement or leaving the unit. I said before, quiet, limit group activity to prevent overstimulating. We will need to set, if they are having inappropriate behaviors such as hypersexual behavior, yelling, screaming, interrupting families, interrupting visiting hours, that sort of thing. We might need to put limits on that inappropriate behavior, but we would follow the same steps as we would before. We'd first, ask them, hey, John, why don't we come over here and sit, and then say, these are visiting hours. It's really, we really can't have you, interrupting other people. They want to visit, that sort of thing. So I'm just going to ask you not to interrupt anymore. And if he can do that, great. If he can't do that, then we might need to set limits. For example, John, while these people are in the day room visiting, because it's difficult for you not to interrupt them, we're not going to have you go into the day room, or we have to have you go back to your room. So setting limits like that, being very matter of fact and very direct, telling them what their behavior is and why it can't, why we can't have that being tolerated. If there are things, if we know they're very hyperactive and impulsive, we may want to remove things that could be dangerous, such as things that could be pushed or thrown. I know that sometimes, on some behavioral units, when it is, quiet and they don't have, hyperactive patients and that kind of stuff, they might have a coffee pot out and let patients fill their own coffee and that sort of thing. If we had a very hyperactive, impulsive person, we would want to remove those types of things that could be easily thrown. Okay, the next nursing intervention, nursing diagnosis is disturbed thought process, and that usually is related to their alteration in their chemicals in their brain, or the manic state. And it says, evidenced by their disorganized thinking, racing thoughts, flight of ideas. It might be, as evidenced by them having delusions or auditory hallucinations, that sort of thing. The outcome is we want to have the patient will have reality-based thinking by a certain time period, as evidenced by, oriented times 3. The patient is able to hold a conversation for 10 minutes. Patient is able to make good decisions, that sort of thing. Interventions here would be one-to-ones to making sure that we are assessing their mental status exam. We want to orient the client to the time and date and where they are, reassure them that they're in a safe place, talk about reality-based conversations. Concrete. We want to have consistency of caregivers and consistency of expectations. If possible, have the same nurse, same tech working with that patient, on each shift. And then everybody has to make sure that we're consistent with the rules and we're consistent with limit setting. We also want to convey acceptance without supporting the delusion. So all of those, basic principles that we talked about, how to manage delusions and hallucinations, we would also want to follow. Such as we've talked about before, don't argue or try to reason with delusions. We want to instill reasonable doubt. Again, I'm not sure how that poison could have gotten into those sealed containers, but I know that must be frightening to you. We want to focus on the feelings conveyed rather than the doubts. Like I said, that must be frightening. Validate the patient's feelings. So what you're saying is that you think that this food is poisoned, okay, and go on from there. Next nursing diagnosis is impaired social interaction. And again, what is that related to? What's causing that impaired social interaction? Many times it is their disorganized thinking. It might be their impulsive behavior. It's all related to, all caused by, that neurotransmitter imbalance. Okay, but if a person is unable to think or have their thoughts organized, they're not going to be able to communicate and interact with people in an organized fashion. If they're having delusions, it's going to make that very difficult for them to interact and be appropriate. So outcomes, we want to have the patient demonstrate socially acceptable behavior. Interventions, for the nurse, we want to make sure that when we're talking with individuals that we are always honest and that we're always respectful. If there's behavior that is inappropriate or we want to make sure that we are identifying the behavior changes that will improve the interaction and maybe how that they could ask for things instead. So for example, if they're yelling in the day room, we could identify and say, John, you're yelling right now in the day room, and that's disturbing, Mrs. Jones over here and her family members. And what I would like you to do is, if you can, to stay in here, if you can be quiet and talk in a soft voice so that we're not disturbing other people. So just being honest and respectful in that manner. And if they start to, not be able to follow those rules or follow those limits, then we may need to ask them, well, let's go down in the end of the hallway and let's talk a little bit. And then we'd have to, gradually start to enforce other interventions. We may need to have them have a timeout in their room. And if they can't do that, we may need to offer medications. And if they would continue to escalate, we may need to give them call security and put them in some kind of restraints if it escalated to that point. Okay, the next one is care deficits or self-care deficit, again related to it's going to be related probably to the mania, but more specifically related to the disorganized thinking possibly, or the inability to slow down to take care of themselves, inability to slow down to take a shower, inability to slow down to eat a meal, that sort of thing. So they tend to ignore hygiene, they tend to ignore eating. Also with a self-care deficit, we could also have altered nutrition. Okay, so just keep that in mind as well. So the outcome is we want the person to perform their own ADLs by discharge might be, one type of outcome. Or the patient will eat 3 meals a day by, discharge. Or the patient will eat 75% of lunch, breakfast, and dinner, along those lines. So interventions, we would want to monitor the person's intake and output. We would want to monitor the way that they are, what kind of hygiene they are. We might need to step in and say every other day a staff member is going to help them take a bath, help keep them organized. So putting certain interventions like that in place. Along with eating, we might need to provide frequent snacks to that person, and many times we want to make sure that we are giving them finger foods, or foods that they can eat while they are on the run, so to speak, that they can eat while they're walking around the hallways, or standing and watching TV, or moving about. And page 431 in your book gives some good examples of that. Again, I talked about assisting with hygiene. We might need to get daily weights to see if the person, how much the person is losing, that sort of thing. The next, sleep pattern disturbance, related to the inability to slow down, or the disruption in neurotransmitters. But if they're unable to slow down, unable to take any time for sleep, they actually seem really energetic, but actually are very, very close to exhaustion. So symptoms that we would see, sleeping only 1 hour per night, hasn't slept over 4 hours in the past 3 nights. Very, appears exhausted, at different points during the day, that sort of thing. So sleep pattern disturbance. The outcome is the patient will sleep, 6 hours a night by discharge, or they will begin to sleep 3 hours for the first 2 nights, and then increasing that, but to come up with an outcome where we're going to see a better sleep pattern. Interventions, we really do want to try to limit the naps that they're taking throughout the day. So if they're up all night but they're taking a 5-hour nap during the daytime, that's going to is disrupting the sleep pattern. So we want to try to limit the naps. We want to do all those things that we know about how to enhance a person's sleep. Nighttime routines, hot bath, a midnight, or not a midnight, but a bedtime snack. We may need to ask the doctor or prescriber for sleep medications. We need to set limits at night, such as, start decreasing the stimulation, limit conversations. They might want to come out at midnight and start to have a long, conversation with the nurses. We have to limit that. Probably they will need to stay in their room after 10:30. They're not allowed to come out of the room unless they have a very specific question for the nurse. And then when they are sleeping, we don't want to wake them for non-essential activities. If they are just finally fell asleep at 1 o'clock at night and it's 7 in the morning and they're still sleeping, we don't unless it's very, very important, we could wait and take those vital signs at 9 a.m. or we could wait and give those medications at 9 a.m. So that's what we're talking about, that not to wake them for non-essential activities. Patient and family education. We want to make sure that we are build an alliance with the patient, a trusting alliance relationship, also with the family members. They need a lot of education, all of them, on medications, education on the illness, and especially on signs and symptoms of relapse. When should I start to be concerned about him or her going into more of a starting a hypomania episode, and what should I do when I start to see that? So signs and symptoms that might be indicating relapse: if they're having difficulty sleeping when they're at home, if they start to exhibit more energy than normal, or they start to become more irritable than normal, if they have an increased talking or have some type of increased religious preoccupation, if they all, have a change in their feelings of self-esteem and kind of moving on into, self-inflated esteem and that sort of thing. That's when are some of those symptoms of relapse, and we need to get into the doctor and look at their medications and see what we can do. Maybe they're under, a certain amount of stress, and maybe we need to kind of withdraw from that stress or get some a different type of medication or increased medication. But definitely some interventions, because if we let it go into a full-blown manic phase, that's going to be very disruptive. They'll probably have to stop work, go into the hospital for 2 or 3 weeks, and we really want to try to avoid that, really major disruption in their life and in their family. So, all right, so that's all the information that I have for you with this PowerPoint. Thank you.